Thank you, Chairpersons. Good evening to all the participants. My sincere thanks to the West Bengal Association of ECHO for giving me this opportunity. So today I will be talking on the approaches to evaluating aortic valve regurgitation. And let me say that the echocardiac approach is the mainstay. And we not only evaluate the etiology and severity, but we evaluate the presence and of regurgitation, the severity and the ventricular size and function. Aortic regurgitation many causes, as you are aware, and the commonest causes are either of the leaflet or of the aortic root. The things are all listed here, and the common conditions are senile and bicuspid, which is very common. The Carpenter's classification classifies the mechanisms into three types. Type 1, where there's enlargement of root. Type 2, A and B, where there's a prolapse of the cusp. And type 3, where there's a poor cusp quality or quantity as in rheumatic heart disease. Bicuspid aortopathy requires a special mention because it's one of the most common causes even today. Slowly, we are seeing more and more cases of bicuspid rather than rheumatic. And the assessment of bicuspid aortopathy is very, very important in assessing aortic regurgitation. And some of the rarer causes, I'll just give a passing mention. Ankylosing spondylitis and Behçet's diseases can also produce aortic regurgitation. Ankylosing spondylitis can produce a thickening of the aortic wall itself, leading to regurgitation, or a thickening of the aortic cusps, or the base of the AML, resulting in improper annular contraction. Behçet syndrome can produce multiple ways of aortic regurgitation, which include vegetation like mobile lesions, echo-free spaces mimicking abscess pockets. As you can see here, there are masses here suggesting vegetation, but they're not actually vegetations. And you can see the multiple prolapse of the aortic leaflets in Behçet syndrome. So this is something to be kept in mind whenever you see an aortic valve prolapse. So whenever you are assessing an aortic regurgitation, it's important to assess the aorta itself. And as per the current recommendations, these are the various places where you measure the aortic root. There are various nomograms to show what is normal and what is abnormal. I'm not going into the depth of it. So establishing a diagnosis of aortic regurgitation requires visualizing the aortic valve itself so that you know what anatomic condition is producing the AR. Doppler imaging, which is of course the most important and sometimes the only clue to diagnosis when the valve appears normal, especially as it can happen in mild to moderate aortic regurgitation. Then comes the estimation of severity of AR, and there are multiple methods of doing it. Some are qualitative, as in the size of the regurgitant depth and the extent of the regurgitant depth. Then there are quantitative measures like the effective regurgitant orifice and the volumetric methods by which you can assess the volume of regurgitant jet. Color flow mapping is the mainstay, of course. It has a sensitivity of more than 95% and specificity of nearly 100% for establishing the diagnosis. As a person grows older, the chances of you picking up a small amount of aortic regurgitation increases. It's less than 1% in subjects less than 40, but it becomes 10 to 20% in the elderly. This is one of the methods of measuring the length of the jet to assess the severity. Not a very good method because so many limitations to it, especially the systemic arterial hypertension, which can produce longer jet than actually the severity warrants. The best method to do it is in the parasternal long axis view because that's where you get the best axial resolution. And these are the various methods of grading depending upon the extent to which the jet goes. The height of the jet is more commonly used rather than the length of the jet. And if you have the jet height in the outflow tract dimensions, the ratio of more than 60 to 65% gives an estimate of the severity. The jet height and LVOT height is used also to classify mild, moderate, and severe aortic regurgitation. The other method is a semi-quantitative method, and that is the assessment of AR by vena contracta. The vena contracta is the narrowest portion of the jet stream from the regurgitant orifice. It's very important when you're doing a vena contracta that you zoom the thing so that your measurement fallacies come down. Also, it's best seen in parasternal long axis view, but whenever you get a good PISA, only then you can get the proper assessment of the vena contracta. Otherwise, your assessment may be fallacious. However, it's quite an easy thing to perform, and it is one of the recommended methods for quantifying the aortic regurgitation. When you have intermediate values of 3 to 6 millimeters, you need another quantitative method to make sure that you're dealing with severe rather than a moderate aortic regurgitation. In the presence of multiple jets, vena contracta cannot be applied because the respective values of vena contracta width are not additive. The next method is PISA. You just heard how PISA is calculated by my previous speaker, and I will not go into the details of it. PISA method, if you can apply it, is a very useful method of quantifying aortic regurgitation. And I've listed the various methods. My previous speaker has already gone into the details of it. Suffice it to say that when you're using PISA, an EROA, that is the effective regurgitant orifice area of more than 30 square millimeter, or a regurgitant volume of more than 60 ml is suggestive of severe aortic regurgitation. PISA method is a very highly recommended method. Sometimes it's difficult to perform, especially in very eccentric jets, but it is one of the best quantitative methods as far as aortic regurgitation is concerned. Now, the other method is the volumetric method, where you go in for the quantitative assessment. We are using the output, that is the stroke volume at the LVOT level and at the mitral annular level. If there is a mitral regurgitation, of course, you cannot use it at the mitral annular level, and then you can use the pulmonic side. However, a lot of discrepancies will come if you're not used to using these methods. So the most important thing here is to measure the annulus very correctly, because as you know, in the calculation, the diameter of the annulus is squared. So any measurement errors in the annulus will, of course, increase the stroke volume at that particular point, and therefore bring in fallacies in your assessment. So the important thing is it is even valid in multiple jets, a little time consuming, but very, very accurate if you can get an accurate measurement going. So the regurgitant volume is actually the stroke volume of the aortic valve minus the stroke volume at the mitral valve. So if you're using the mitral valve. So the regurgitant fraction is a fraction that is assessed as stroke volume aortic valve minus stroke volume systemic valve by the stroke volume at the aortic valve into 100. And limitations in assessment of regurgitant volume by the volumetric method is that it's technically demanding and you're using multi-stage calculations. However, if you're very used to it, if you're doing it regularly, it is a very good method. And you of course have to be very careful about measuring the mitral annulus. The continuous wave Doppler is the other thing that is used to assess the severity. It's a very simple approach because it simply compares the density or the darkness of the envelope. The larger the regurgitant volume, the darker the regurgitant jet is on the continuous wave Doppler. The highest velocity is an early diastole if it is a severe, and if it is a mild AR, the jet shape is flat. One of the other methods of using a continuous wave Doppler is the use of pressure half-time. Assessment of the pressure half-time requires good Doppler beam alignment. A careful probe angulation is often needed. Because this parameter is influenced by chamber compliance and chamber pressures, it serves only as a complementary finding for the assessment of severity. Measurement of diastolic flow reversal in the descending aorta is another method. It is very, very useful, and it is a very strong parameter for evaluating this schematic diagram. This end diastolic assessment should be at least more than 20 centimeters per second for you to say that it's a holodiastolic aortic regurgitation. So what are the recommendations for estimation of severity? The color flow area of the regurgitant jet is not generally recommended. Both the vena contracta measurement and the PISA methods are recommended approaches to evaluate the severity. Adjunctive parameters should be used when there is discordance between quantified degree of regurgitation and the clinical context. So this gives in a nutshell, this is a very simple thing to use so that you are sure of what you're doing. A more exhaustive chart is given in the Journal of American Society of Echocardiography 2017, where guidelines for assessment of valvular regurgitation is published. I won't go into the details of it. I'm sure any of you can download it and keep it in your lab to know what is severe, what is mild, and what is moderate. In fact, they have used two classifications of moderate. One is moderate, and the other one is moderately severe, which was not there in the earlier classifications. They have also given an extensive algorithm to differentiate between mild AR and severe AR. I will not go into all the details for want of time. So when you are, what do? We must understand the implications of our measured variables to avoid inappropriate treatment strategy. So when you're doing the assessment of aortic valve, you are evaluating the valvular heart disease mechanism, you are assessing the valvular heart disease severity, and you're evaluating the LV function. So there has to be an integrated approach of multiple parameters, like like I said, continuous wave Doppler, color Doppler, and 2D dimensions and volumes of the left ventricle. Whenever there's a inconsistency, you need to recheck your findings and or assess the correlation with clinical data. Now, some examples of those conditions I've listed which can cause. Here you see an aortic dissection. You see the dilated aortic root. There are three reasons why an dissection produces severe AR, proximal dissection. One is the flap itself can collapse into the wall, producing severe AR. Sometimes the dissection ruptures through the annulus, producing severe AR, or the aorta itself dilates, which generally happens with dissection, and that widens the annulus and produces severe AR. This is the same patient where you see the flap up to the ascending aorta. So, transthoracic echo has a very low sensitivity and specificity. So whenever you're suspecting dissection AV, you need to go in for a CT imaging or a transesophageal echo. We have done any number of transesophageal echoes for patients with dissection. There is really not much of danger as long as you're careful. The other very important role for transesophageal echo in the assessment of AR is in the assessment of endocarditis of the aortic valve. This is one such patient where you can see the mask going in and out of the LVOT. This patient I've used to show why transesophageal is important. You see the large shaggy mass there, but what is important is you see the satellite lesions on the mitral valve here, and also the fenestration or the perforation within the mitral valve. So transesophageal echo is a must in any patient suspected of endocarditis as a cause for the AR. The sensitivity of 2D for detection of vegetations is 85% to 90%. This is another important case which shows that there is a mass there and there's a eccentric AR. Now, if you see the 3D, you see a punched out perforation here because of the aortic. So this is just to emphasize that 3D is also increasingly coming into picture. This is a case of an aortic annular abscess, where again you see almost a dehiscence of the valve, but you don't see much of aortic regurgitation. But when you see the transesophageal echo pictures, you see that there is a root abscess here, and there's a partial dehiscence, and there's a severe aortic regurgitation, which you can make out in the color. So in assessing AR in prosthetic valves, we need to have the AR value area in short axis so that we can gauge the severity of the. The next step is to, of course, quantify. I won't go into details. As I said, all the recommendations today use the LV end systolic dimension and the LV volumes to decide when we have to do a replacement. I won't go into details of chest echo because it is a thing of the past. Earlier in the 80s and 90s, chest echo was used to assess patients who required valve replacement in the presence of borderline LV function. We are no longer doing it. Cardiac MRI has come into increasing use in the assessment of aortic regurgitation. It's especially useful in assessing myocardial fibrosis and the need for Bentall in patients with bicuspid aortic valve. The current indications for cardiac MRI include suboptimal images when there is a discordance between echo and Doppler findings, when there's a discordance between clinical and severity of AR. So there are various indications, but these are all constantly evolving. There are no hard and fast rules. This I've included this to show the leak, and when you have this, you can easily measure by software tools the vena contracta. And this is phase contrast MRI. I've used this to show you that you can plot the graph of the increase in the LV dimension during diastole and get a very accurate calculation of the regurgitation fraction and regurgitation volume. Now, there's an increasing use of LV systolic strain. We are using LV systolic strain in all cases of AR with even normal EF. This is one study which was published in 2011, where they have shown that in 64 patients, they have shown that strain is a very good predictor of future deterioration of a patient with AR who has not undergone surgery. And there is another study which shows the incremental prognostic utility of left ventricular global strain in patients with significant. They have used the cutoff point of 18.5%, and if you see, those patients who had a low strain and were operated did very well, whereas those who were on medical follow-up rapidly deteriorated once the strain dropped below 18%. So, what are the current recommendations? AVR is indicated for asymptomatic patients with chronic. I'll just take another minute or two, chairpersons. Kindly bear with me. Class 1 for patients with symptoms, and class 1 with patients with asymptomatic patients LV dysfunction. There's a class 2A indication for those who have an LV dimension of more than 50 or an LV end-systolic dimension of 25 per square meter, or an LV end-diastolic dimension of more than 65. Now, we are revisiting a lot of things. Today, we have shown, for example, trials have shown that vasodilators are not useful in prolonging survival. Similarly, they are now increasingly questioned the arbitrary value of 2.5. Now, this trial, for example, has shown that patients rapidly deteriorate once they go beyond even 2 centimeters of LV end systolic dimension index. Now, this is a study which showed that patients who underwent AVR, they showed a lot of fibrosis, interstitial fibrosis in the early stages, and which persisted in the late stage also. So we have now come to the use of MRI to show septal, mid-septal scars. And when you have these mid-septal scars, this study showed that many patients had mid-septal scars, which was corroborated by histopathological function. So MRI is now increasingly used to time early surgery so that we do not have residual LV dysfunction. Now, a special word on the indications for bicuspid aortic valve and aortopathy. Earlier, the recommendation was if you had a dimension of 5 centimeters, you send for surgery. That has been altered to 5.5. And if you have any history of dissection in the family, then at 5 itself, you send the person for surgery. Now, another useful method is the use of BNP in patients with AR. People who have a high BNP should be sent for early surgery. So, ultimately, coming to the conclusion, and what do? We understand the implications of the measured variables to avoid inappropriate therapy. We need an integrated approach, check for consistency, and assess the correlation with clinical data. Echocardiography remains the cornerstone. In cases of discordance, we need to send to an expert echo lab which deals with quantitative echocardiography, or send the patient for a MRI. Thank you very much for your patient listening.